Osteogenesis imperfecta. Osteogenesis imperfecta, abbreviated OI, is a grouping of rare disorders affecting the connective tissues, causing bones to be very fragile and easily broken. Osteogenesis imperfecta is caused by a defective gene, an autosomal dominant trait. This defective gene results in insufficient production of type 1 collagen, or collagen that is of poor value. Type 1 collagen is a vital component of the connective tissues in the bones. Osteogenesis imperfecta is typically inherited. However, in some cases, a genetic mutation can cause it. In cases of an inherited gene, a single copy of the disease is received from either parent's gene, whether it's the maternal or paternal side. This gene will express itself as dominant, overtaking a normal gene, resulting in the presence of OI. Then, in cases where OI occurs with no previous family history of the disease, is a result of a spontaneous genetic mutation. Parents carrying the OI defective gene are at risk of 50% for passing on the gene to an offspring. OI equally evolves in men and women. The general prevalence of OI is estimated 0.5 per 10,000 individuals in the U.S. That is approximately 20,000 to 50,000 Americans living with OI in the U.S. There are four main types of osteogenesis imperfecta with specific physical features and symptoms that vary case by case. Type 1 is the most common, typically the mildest form of osteogenesis imperfecta. Type 2 is the most severe type of osteogenesis imperfecta. Type 3 is the most critical among young children who survive the neonatal time period. And type 3 is acknowledged as the most varied form of osteogenesis imperfecta, for individuals can moderately be affected or severely affected, resembling type 3. Osteogenesis imperfecta type 1. Type 1 is the most common and typically the mildest form of osteogenesis imperfecta. It can be characterized by multiple bone fractures generally occurring within childhood through adolescence. Fractures in type 1 begin when a child with OI begins to walk. It is rare that fractures occur on neonates within type 1. A peculiar feature with type 1 is blue sclera. This is the discoloration of the whites of the eye to a blue tone. Individuals with OI type 1 may develop a triangular facial profile with an abnormally larger head, referred to as macrophilia. 50% of cases with OI type 1 individuals will experience growth deficiencies postnatal, resulting in shorter statures. Nord further reports that 20% of those individuals will develop scoliosis or kyphosis, an abnormal lateral or outward spine curvature. Additional symptoms may include hyperextensible joints and hypotonia, and thinner skin that is easily bruised. Osteogenesis imperfecta type 2. Type 2 is the most severe type of osteogenesis imperfecta. Infants affected by OI type 2 experience life-threatening complications, oftentimes causing death in the womb or shortly after the infant is born. OI type 2 infants typically have reported lower birth weights, small limbs, blue sclera, extremely fragile bones, and numerous fractures existing at birth. These fractures typically evolve in malformation of the long bones, typically including the leg bones and rib bones. The symptoms associated with OI type 2 include altered appearances such as a small thorax, undeveloped lungs that cause congestive heart failure, small narrowed nose, a small jaw, abnormal large spots on the skull, thin fragile skin, and hypotonia. Individuals with OI type 2 typically have a lower life expectancy rate if survived after birth. Osteogenesis imperfecta type 3. Osteogenesis imperfecta type 3 is the most critical type among children who survive the neonatal stage. Type 3 at birth can present itself exceptionally through fragile bones, multiple fractures, malformed bones, small chest, and soft calvarium. Individuals with OI type 3 physically will have a triangular face shape caused by the overdevelopment of their head and underdevelopment of the facial bones. This typically results in the person's head being larger than the body. Other symptoms of OI type 3 include scoliosis, kyphosis, blue sclera, hearing impairment, Osteogenesis imperfecta, and particularly shorter statures, adults typically measuring under 3 feet. According to the National Organization for Rare Disorders, in some cases of OI type 3, individuals will develop pulmonary insufficiencies, and severe bone malformations resulting in the required use of wheelchairs. Osteogenesis imperfecta type 3. OI type 4 is acknowledged as the most variated form of osteogenesis imperfecta, for individuals can experience this type of OI differently case by case. The diagnosis for type 4 can occur at birth, although in most cases transpires later. This type of OI fractures are common before adolescent age. Individuals may experience mild to more moderate bone malformations, long bone fractures, vertebral compressions, ligament laxity, and may develop scoliosis or kyphosis. OI type 4 appearance may include triangular facial structures and shorter statures. Blue sclera developed within type 4 typically fades within infancy and adolescence age. Individuals may also experience hearing impairment and Osteogenesis imperfecta. Below is a 14-year-old boy with Osteogenesis imperfecta. You see his back view as well as his x-ray view. The red line in the x-ray is the outline of his spine. The two arrows point to two separate points of scoliosis apparent in his spine. This view will show you a significant severe case of scoliosis, often found in individuals living with Osteogenesis imperfecta. Diagnosis of Osteogenesis imperfecta is done through various tests and procedures. A clinical evaluation is taken with patient's history and symptoms. Blood tests can be done to detect the genetic mutation. X-rays will allow physicians to see current and previous fractures. In the prenatal stage, ultrasounds, amniocentesis, and CVS tests are performed. Ultrasounds will reveal bowing and fractures present in the fetus. Amniocentesis is a test that extracts amniotic fluid from the surrounding disrupting developing fetus. In CVS testing, also known as chorionic villus sampling, is a test that extracts tissue portions from the placenta. Both amniocentesis and CVS testing will allow osteogenesis imperfecta to be shown once examined. OI non-invasive treatment. Hydrotherapy has been proven to be very helpful as water reduces the probabilities of fractures in individuals with osteogenesis imperfecta. A common medication used for OI includes bisphosphonate, a class drug that prevents loss of bone density. Bisphosphonates can be distributed orally or intravenously, reducing bone reabsorption. In individuals with severe OI, medical bisphosphonates reduce bone pain and number of fractures that can occur. Bisphosphonates, however, can only be distributed by trained professionals as this treatment requires very close monitoring. Immobilization is also a course of treatment. This includes casting, bracing, and or splinting fractures. This keeps bones secure as they heal, acting as a protective barrier, preventing further fracturing. Exercise is also used to help patients with OI strengthen their muscles. OI surgical and invasive treatments. Rodding surgery is where metal rods are placed into long bones to reinforce bones and prevent further fractures. Spinal fusion is a surgery that realigns and fuses the spine bones together. It is recommended when the progression of scoliosis is quite severe. Dental procedures can be done to correct dental abnormalities that develop in those with OI. Clinical trials. According to clinicaltrials.gov, in January 2017, there were just 7 trials listed. However, now there are 9. Of the 9 posted, 8 are still accepting applicants to the trials. One of the 9 is currently closed. Each clinical trial includes their own courses of intervention. Growth hormone therapy, GH, is also available for individuals with different forms of OI. GH therapy has proven to improve the collagen production and increase bone density.